Again, I want to introduce Dr. Ha, one of our honor speakers, and he's going to talk to us about the cervical deformity correction.
Thank you. Good afternoon. It's my great pleasure and honor to share my clinical experience and research in cervical spinal deformity surgery. So today's my presentation is more focusing on the neuromuscular disorder. My name is Yoon from Yonsei University, Seoul, Korea. I have no disclose to make regarding this topic presentation, but I'd like to disclose that I have a strong spinal deformity fellowship training in UC San Francisco and very good memory about the people in San Francisco. So as we know, the major structural component of cervical alignment are bone, ligament, muscle, and neural structures. Probably bone and ligament constitute the static aspect of the alignment, while the muscle and neural structures contribute to the dynamic aspect of the cervical alignment. In this sagittal plane, the spinal alignment is harmoniously arranged and changed reciprocally in response to the alignment of the next segment. When a patient has a higher thoracic kyphosis, the cervical spine exhibits increased cervical lordosis to maintain horizontal gaze. In our previous study on Parkinson's disease, we observed that patients with Parkinson's disease showed a higher C27 SVA at the same angle of thoracic kyphosis compared to the normal population. This observation was linked to the decrease in neck extensor muscles, resulting in the reduced compensatory mechanism. This neuromuscular decompensation serves as one of the pathophysiologic mechanisms contributing to cervical spinal deformity in Parkinson's disease. During our multiple regression analysis in Parkinson's disease patients, we found that the higher C27 SVA is strongly associated with both the advanced stage of Parkinson's disease and higher thoracic kyphosis. The primary goal of the treatment of the cervical deformity is to restoration of the sagittal alignment, which leads to the improvement in the horizontal gaze, reduce the neck pain, enhance the swallowing and respiration, and the prevention of the neurologic deterioration. Before beginning the presentation on neuromuscular deformity surgery, I would like to summarize the basic surgical principle of cervical deformity surgery. This principle was a book chapter written together with Chris Ames when I was in UC San Francisco. When patients present with cervical kyphosis, surgeons should investigate the two important parameters. The first parameter is the location of the apex of the cervical kyphosis, and the second one is the curve flexibility. If the deformity apex is located at the craniocervical junction, osteotomy at the craniocervical junction is required. On the other hand, if the apex is located in the subaxial spine, we need to assess the curve flexibility. If the curve is fully flexible in flexion extension X-ray, the deformity can be corrected through the posterior alone procedure, such as Smith-Peterson osteotomy or minimal facetectomy. However, if the deformity is not reducible in extension X-ray, then we categorize the patients based on the location of the apex. If the apex is located between the C3 to C6, in order to avoid the vertebral artery injury, circumferential osteotomy such as AP or PAP type osteotomy is required. On the other hand, if the apex is located between the C7 to T1, we can correct the deformity through posterior alone procedures such as C7 or T1 PSO. However, compared to the degenerative cervical kyphosis, patients with neuromuscular cervical deformity exhibit a different clinical outcome. This is because of involuntary neck movement increase the risk of postoperative kyphosis, hardware failure, pseudoarthrosis, and adjacent segment degeneration. As a result, patients with neuromuscular cervical deformity should be treated with different principles, focusing on the management of involuntary neck movement. When performing the surgical correction of neuromuscular cervical deformity, we still adhere to the surgical principle used in the degenerative cervical deformity correction. These principles include the spinal cord decompression, strong mechanical fixation to prevent pseudoarthrosis or instrument failure, and the correction of cervical deformity. However, in addition to this general principle, we must also incorporate the principles of management of involuntary movement to ensure the successful surgical outcome. When we need to control the involuntary neck motion, we have several specialized protocols to consider. These include the perioperative Botox injection, surgical division of dystonic muscles such as SCM, platysma, semispinalis, or utilizing the intrathecal baclofen pump for managing the generalized dystonia. We investigate the role of botulinum toxin injection on the revision surgery in cerebral palsy patients after the cervical spine surgery. We found that the perioperative Botox injection decreased the reoperation rate. If patients with cerebral palsy are accompanied by kyphotic cervical deformity, the risk of unfavorable surgical outcome is also increased. In patients with cerebral palsy, repetitive and dyskinetic movement can induce the cervical spondylotic myelopathy more severe. In this study, we examined the role of deformity correction and the clinical outcome in 31 cerebral palsy patients. We divide our patients into 13 deformity correction group versus 18 non-correction group according to this radiological parameter, C27 curve angle, C27 SVA, T1 slope minus cervical lordosis. From this study, we observed that the deformity correction group showed a significantly higher improvement in neck disability index compared to the non-correction group. The improvement in neck disability index is associated with the improvement in the C27 SVA. In this slide, I propose the classification of neuromuscular cervical deformity based on the surgical perspectives rather than a pathophysiological or neurological perspectives. Patients can be divided according to the frequency of involuntary neck movement. If a patient exhibits higher frequency neck motion, we label it as a hyperkinetic deformity. On the other hand, if the frequency of neck movement is low or absent, we classify the patients having a hypokinetic cervical deformity. Within the hypokinetic deformity, there are two subcategories based on the muscle tone in the both agonist neck flexor muscle versus antagonist neck extensor muscles. If there is a rigid or spastic muscle tone in the agonist neck flexor muscles, we refer to it as a hypertonic hypokinetic deformity. In this condition, the patients cannot touch the posterior part of the head while lying down on the bed in the middle panel of the figure. On the other hand, if there is a decreased muscle tone in the antagonist neck extensor muscles leading to the cervical kyphosis, we classified it as a hypotonic hypokinetic deformity. Sometimes we call the drop-head syndrome. In this case, the patients can touch the posterior part of their head while lying down on the bed. So I'm presenting a case of a hyperkinetic cervical deformity, which is the most common type of cervical deformity in cerebral palsy patients. This case is a 50-year-old gentleman who came to the hospital with a complaint of cervical thoracic deformity and progressive myelopathy. The chief complaint was a progressive weakness and bladder bowel incontinence persisting for 3 to 4 years. The patient had previously undergone the 2-level ACDF, C345. The patients present with shoulder pain, arm pain, double incontinence. On neurologic exam, Hoffman sign and the increased DTR were noted. Additionally, both upper arm weakness was observed in grade 2 to 3. In the preoperative clinical photo and videos, the patients exhibit the significant gross cervical deformity. Neck was tilted to the right side, and there was a rigid contraction of the anterior neck muscles. In the plain X-ray, the apex of scoliosis is located in the cervicothoracic junction. However, in the lateral X-ray, the apex of kyphosis is located in the mid-cervical area. In flexion extension X-ray, the cervical deformity cannot be fully reduced, indicating that this patient can be classified as having a rigid mid-cervical deformity. The cervical CT scan shows a significant disc and facet joint degeneration along with the bony spur formation. These severe form of degenerative changes are typical findings in cerebral palsy patients. The MRI shows the degenerative change in the disc and bony spurs along with the facet degeneration. Additionally, there are signal changes on T2 weight images and atrophies observed in the cervical spinal cord. In these patients, I summarize the problem include the progressive cervical myelopathy, progression of cervicothoracic hyposcoliosis, dystonic cerebral palsy, and the need for revision surgery. To address all of these issues together, I propose the comprehensive surgical approach, which include the cervical decompression to alleviate the myelopathy symptoms, deformity correction and the stabilization to improve the cervicothoracic hyposcoliosis, and the specific options to control the cervical dystonia for better surgical outcome. I prefer stage operation for this type of neuromuscular patients who require circumferential osteotomy and instrumentation. In the first stage, I perform anterior spinal fusion with the cervical cages and anterior neck muscle division to control the involuntary neck motion. 1 week after the first operation, the second operation involved posterior long instrumentation and fusion with a facetectomy. I make every effort to preserve the bony structure as much as possible. However, detach the muscle from the bone to decrease the effect of a muscle contraction on the stability of the spine. Excessive bony removal for achieving the perfect alignment can sometimes lead to postoperative instrumental failure and instability. Therefore, preserving as much bone as possible is essential for ensuring the long-term stability. I also consistently use O-arm navigation for screw fixation. O-arm navigation provides more precise screw positioning with higher brow strength, enhance the accuracy and the reliability of the surgical procedures. Also, monitoring the motor evoked potential is mandatory. In anterior surgery, my preferred device is a zero-profile cage. The unidirectional anchor screw in this cage provides excellent stability, and it also allows for additional kyphosis correction during the posterior surgery. To control the dystonic neck motion, a transverse incision was made at the suprasternal notch. We detached the SCM muscle from the sternal notch and the medial 1/3 of the clavicle. This approach helps to minimizing the involuntary neck motion after the surgery. In the posterior surgery, long instrumentation was conducted extending from C2 to T5. Fasciectomy and bone graft procedure were also performed. This intraoperative photograph displayed the long instrumentation extending from C2 to T5. This multiple rod construct covered the area of the apex of both scoliosis and kyphosis, providing the comprehensive stabilization and correction. Compared to the preoperative X-ray, the postoperative X-ray demonstrates a significant improvement in both coronal and sagittal alignment. Compared to the preoperative video clip, the postoperative video clip on the right side shows the coronal and sagittal plane alignment are well restored. Additionally, there is a softening of the anterior neck muscle is also observed. The next case is also the hyperkinetic cervical deformity patient in cerebral palsy. 47-year-old man visited my clinic due to the progressive quadriplegic paralysis. The patient, the history of 2 years of progressive weakness and left arm and neck pain, and past medical history has a cerebral palsy, schizophrenia, and a hypereosinophilic syndrome. And neurologic exam shows the decreased motor power in all 4 extremities. And the preoperative video clip shows the hyperkinetic dystonia in neck motion. The patients exhibit increased muscle tone and the high frequency of the involuntary muscle contractions. Particularly, dystonic muscle contractions are accelerated when the patients start speaking. The standing plane X-ray of the cervical spine demonstrated severe kyphoscoliosis, and whole spine standing AP and lateral view showed marked deformity affecting the cervical spine. This cervicothoracic junction deformity caused a significant shoulder imbalance. However, the global sagittal alignment in thoracic and the lumbar appear to be fine. The cervical MRI shows the herniated disc in the 5, 6, 7 and the stenosis. Additionally, the spinal cord shows a signal change on T2 weight MRI, indicating the compressive cervical myelopathy and atrophy. The CT scan shows the facet hypertrophy and the rotational deformity. Similar to the first case, I performed the 2-stage operation. During the anterior approach, I conducted the ACDF from C4 to 7 using zero profile peak cage and insert the unidirectional anchor screw. Additionally, I performed a resection of the left SCM muscles to control the dystonia neck motion. This is the X-ray taken immediately after the first stage operation. We can observe the slightly improvement in the coronal and sagittal alignment. 1 week later, I proceed to second stage operation using the posterior approach. I conduct the instrumentation from C2 to T11 with OARM guidance, ensuring the pedicle screw placement. Fasciectomy was performed the C3 to T10. The sagittal and coronal deformity correction was carefully performed under neuromonitoring. This intraoperative photograph shows the rod assembly after the correction. We can observe the scoliosis has been corrected quite well, resulting in significant improvement in the alignment of the spine. And this AP and lateral X-ray shows the quite significant improvement in both coronal and sagittal plane deformity. Based on these 2 illustrative cases, I would like to recommend the following surgical principle for cervical deformity correction in hyperkinetic cervical deformity. Spinal cord decompression, strong mechanical fixation, correction of cervical deformity with a minimum osteotomy, and the perioperative Botox injection to improve the fusion rate. The second type of neuromuscular cervical deformity is hypokinetic, hypertonic cervical deformity. As you can see in this video clip, the patients exhibit a rigid anterior cervical neck muscle and contracture, but no increase in frequency of neck motion. The patients experience the difficulty in ambulation and maintaining the horizontal gaze. So she cannot touch the posterior part of the head when she was lying down. In the preoperative X-ray, the significant cervical kyphosis was noted. The chin-brow vertical angle was measured at 57 degrees, indicating the abnormal forward inclination of the head. However, global sagittal alignment is relatively well preserved. The CT scan shows a significant degenerative change in the mid-cervical spine. Additionally, the kyphosis was not reduced in the supine position, indicating the presence of a rigid cervical deformity. I summarized the list of problems for these patients. The patient has a progressive cervical kyphosis and intractable neck pain and inability to maintain horizontal gaze. But neurological status is intact. No myeloradiculopathy was detected. We decide cervical deformity correction combined with controlling the cervical dystonia. This patient has a mid-cervical subaxial deformity, which is a fixed type. Natural curve will decide to perform circumferential osteotomy to address the cervical deformity correction comprehensively. During the first anterior surgery, we conducted the anterior cervical discectomy and fusion from C3 to 7. Additionally, bilateral SCM tendon resection was performed at the bilateral sternum notch. 1 week later, the second posterior surgery was performed from C2 to T4. The multilevel fasciectomy was added from C7 to 7, C3 to 7. And 1 year after the whole spine X-ray film shows the cervical alignment is well restored and maintained. For patients with hypokinetic, hypertonic deformity, thorough neurological investigation is necessary to identify any underlying neurologic disorder contributing to this condition. Typically, combined anterior-posterior circumferential fusion is required to address the deformity comprehensively and achieve the strong stabilization. In addition to the fusion procedure, division of the affected neck muscle can significantly improve the clinical outcome. The last classification is hypokinetic, hypotonic deformity, which we often refer to the drop head syndrome. Hypokinetic, hypotonic cervical deformity is a less common but highly disabling condition. It's mainly attributed to the extensor muscle myopathy or may arise secondary to the neurodegenerative disorders such as Parkinson's disease, ALS, and so on. Understanding the underlying cause of this deformity is essential and crucial for accurate diagnosis and providing the effective treatment option to improve the patient's condition and quality of life. Various factors can influence the disease progression and the treatment decision in patients with neuromuscular deformity. It is essential to thoroughly investigate the underlying neuromuscular pathophysiology and understand the natural course of the condition. In some cases, the disease progression may be self-limiting, resolving within a few months to years. This is the management algorithm of the hypokinetic, hypotonic cervical deformity patient. First, we conduct the investigation into underlying neurophysiology, which requires a collaborative effort with a neurologist or rehabilitation specialist. If the underlying disease is benign or self-limiting, non-surgical treatment is the initial consideration. If the prognosis of the primary neurological disorder is unfavorable, surgical treatment is rarely considered. In case where non-surgical management proved ineffective, surgical treatment becomes necessary. The severity of the neurological status and the HRQOL significantly influence the decision-making procedure regarding the short or long deformity correction procedures. So myelopathy patients with poor general performance, probably we can treat the patient's myelopathy alone. But if the general performance is good, then we control the myelopathy as well as the deformity together. These patients present to the hospital with complaint of progressive quadriparesis and neck pain. This patient has a drop head posture. The medical history has a previous diagnosis of unknown neurologic disorder and the history of cervical cord tumor resection. Patients try to extend the neck, but eventually fail to keep extension position. Flexion extension X-ray shows a significant mid-cervical deformity, and CT and MRI show the marked degenerative change in the disc and facet joint. Spinal cord has a signal change and atrophy. After undergoing the combined stage operation, patient's cervical alignment has been successfully restored. So in patients with hypokinetic, hypotonic deformity, it is crucial to conduct a thorough investigation of any underlying primary neurological disorder before initiating treatment. Typically, combined anterior-posterior surgical approach is necessary for addressing the deformity correction comprehensively. When planning the surgery, special attention should be given to provide a strong mechanical support for the inactive extensor muscle to achieve the effective stabilization and the correction of cervical alignment. In conclusion, it is essential to treat neuromuscular cause of cervical deformity differently from static non-neuromuscular degenerative deformity. Hyperkinetic deformity patients has a higher risk of postoperative complications such as pseudoarthrosis, neurologic deterioration, hardware failure, and kyphosis progression. Perioperative botulinum toxin injection helps to control the hyperkinetic neck motion. Dystonic muscle division is required to control the intractable hyperkinesia. Strong anterior and posterior instrumentation is mandatory for neuromuscular deformity correction. You can have more information about this topic in this review paper published in Neurospine. Thank you for your attention, and see you very soon at Las Vegas for University Spine Symposium. Thank you.
Dr. Hart, thanks for a great overview of the treatment paradigm for the neuromuscular cervical deformity. So we do see a number of patients with movement disorder and including dystonia coming with cervical deformity. Always wondered, have you tried send these patients to get a DBS first and perhaps treat the movement disorder first and then operate later if they don't have a significant neural deficit?
Oh, that's a great question. So especially CP patients, there are so complex pathophysiology involved in the movement disorder. It's not easy to control the single target DBS. There are very variations in terms of the outcome of DBS surgery in cerebral palsy dystonia patients. So mostly the patients complain the the pain related with the dystonia and postural deformity. So during this surgery, we can not only the deformity correction, but also sacrifice the muscle that involve the severe dystonia, such as the SCM. Also, when we do the posterior approach, we detach the muscle from the bone as much as we could. Therefore, patient has mostly satisfied with the low, the less severe residual movement disorder after this type of surgery. So I think the cerebral palsy patients, this type of surgical process is the first line compared to DBS. But Parkinson's disease is another story. But Parkinson's disease patient usually is well responsive to the DBS, but that response is quite better in the positive symptoms, such as the tremor, rigidity, things like that. But postural deformity is not so much responsive from the DBS. So if camptocomia is severe and it's not responsive to the Parkinson's medication, we may consider the camptocomia surgery as the first line. Yeah.
And then second question I have for you is how do you pick your LIV? I see sometimes we go down to T5, sometimes T2 may be enough. Like, what is your how do you make that decision?
Yes, that's also a great question. So it's more complicated than any other, spinal deformity patients. But usually I'd like to cover the whole deformity area as much as I could. So if the deformity is located in the cervical area alone, where we only correct the deformity, the instrumentation from C2 to T5, says the semispinalis, the end of semispinalis, and if the deformity involved the cervical thoracic area as well, we can go down to whole thoracic T11. Yeah. Okay. Oh, okay. Thank you.
Yoon, terrific talk again. Your expertise with the cervical OPLL and now deformity is terrific. And when do you need to? You showed a lot of anterior and posterior combined surgeries. When do you find that the surgery is rigid enough, the spine is rigid enough that you may need to go posterior first to make releases, then anteriorly, then posterior? Do you ever do a 3-stage surgery?
Usually the cerebral palsy patients is rigid, but it's not fully rigid. So therefore, when we do anterior surgery first, we can mobilize the spine quite remarkable. So therefore, when we do posterior surgery, we just do the minimum fasciectomy and make alignment. Therefore, we don't need the posterior anterior posterior surgery for this type of patients. When you do the osteotomy more and more, such as Smith-Peterson, I have a case that has instrument failure in because of the residual dystonic motion. So when you do the posterior surgery, just the fasciectomy is my best, the most aggressive bony osteotomy procedure. Yeah.
Thank you so much for a wonderful talk. I was wondering, is there ever a role for preoperative traction, especially in the hypertonic sort of subgroup?
So we can choose the preoperative traction in severe form of deformity, but fortunately in my surgical series, I don't see the patient who need preoperative traction. So usually, in the traction during the surgical procedures, anterior posterior, is enough to correct the alignment. Yeah.
Thank you.
Yeah, Dr. Hart, one last question. Sometimes when you do front and back, you do the ACDF, the cervical spine fuses great, but cervical thoracic junction, sometimes the fusion is always a little bit problematic, especially if you have to do laminectomies down to C7 to decompress the spinal cord. Any tricks to kind of enhance fusion? I see that on some of the slides you said you do use BMP in the posterior cervical area.
Yes, I always use BMP, especially in cerebral palsy patients. Also, I do a fascicectomy, but I do not perform laminectomy in these patients. Most of the pathophysiology of this cerebral palsy cervical myelopathy is dynamic compression. If we stabilize the spine, the spinal cord is relaxed, and improve the neurologic functions even without posterior decompression. We already done the anterior decompression. Therefore, we only perform the posterior fixation and minimal fascicectomy and put the bone graft, mixed autobone, allobone, DBM, BMP together. It's a big, long construct we need to fuse. Yeah.
Because you don't typically do laminectomy, you're not worried about the seroma as much.
Yeah, that's right. That's right. Yeah.
What about the anterior cervical space? Do you use BMP? I know some people use very low dose. On some occasions, whether you're
but the cerebral dystonic cerebral palsy patient, they already have some problem in dysphagia and swallowing problems, and also had a long-term contracture of the anterior neck. Therefore, when you do the realignment surgery, there's a high risk of dysphagia. So therefore, if we use the BMP in the anterior, I think the risk of dysphagia is significantly increased. So I don't use BMP. Yeah.
Along those lines, I know a lot of people with Parkinson's will place a OG or NG feeding tube so they can deliver Cinemet and other medications perioperatively. But do you do that prophylactically for any other pathologies to mitigate dysphagia risk?
So there is also good point, but when we decide the surgery, I ask the patient and patient family the importance of the nutritional support, especially high protein diet. So there are liquid form of diet, and many things are in public. I mean, we can buy in the public area. So we ask patients to take the high protein diet for few months. Also, I prescribe the Forteo to enhance the bone quality. Yeah. Okay, please. We stop instrumentation and C2 to preserve the motion of the cranial cervical junction. But there is a high risk of adjacent segment issues, especially in CP patients. So when the C1-2 instability develops from the surgery, then we go up to occiput. Yeah. So I do not go up to occiput as a first line surgery. But if there is ASD issues in C1-2 area, we will go to occiput. Yeah. Thank you.